Good afternoon, everybody. Welcome to the launch of the ImpENSA project. And we would like to welcome all of you in the audience and also everybody that's joining us online. We have in excess of 150 people that have registered for this event this afternoon. So we are really, really thankful for your time, for your support. And we are excited to share with you our journey of the ImpENSA project. So I would like to hand over to Professor Hester Klopper. She is the Deputy Vice Chancellor for Strategy, Global and Corporate Affairs from Stellenbosch University, just to perform an official word of welcome. Thank you.
Well, good afternoon. Goeiemiddag, molweni. And with our colleagues from abroad, I have to say guten Tag. And I know there's Polish colleagues that's joining this program, so I have to say dzień dobry. Very pleased that everyone is part of this project. As you've heard, my responsibility at the university is around global affairs, so whenever I get invited to welcome partners from around the world and our colleagues from other parts in the country, it is indeed an honor and a pleasure, because this is so critical for Stellenbosch University, and more so with the official launch of this program here this afternoon. It's always difficult to pinpoint some people, because everyone is important, and as Professor Blauer said, that quite a number of people are online, so welcome to everyone, but I do want to most probably highlight some of the people in the audience here this afternoon that are our guests and that will fulfill specific functions here. And our main guest speaker, Professor Shane Norris, here this afternoon. Also, our guest speaker, Mr. Gilbert Chitautsi, and I hope I've pronounced and done justice to the surname, Professor Bertolt Koletsko, who is the project coordinator for the ImpENSA consortium, Professor Elmi Miller, who is the Dean of the Faculty of Medicine and Health Sciences here at Stellenbosch University, Professor Karen Baikes, who is the Deputy Dean for Teaching and Learning here at the faculty. And then, of course, Professor Mariana Krier, who is the Executive Head for the Department of Pediatrics, Child Health here at Stellenbosch. But I thought it's also important to acknowledge the partners that has been joined in this program. And I know, just listening, speaking to Bert before we started, was to listen to the immense work and the impact of the work that has already been done and how it has come together is indeed a success story here this afternoon. The partners, and I've heard there's an easy way to say this, the LM University, but to be specific, Ludwig Maximilian, based in Germany. Then we have the Medical University in Warsaw in Poland, University of Southampton in the UK, Northwest University in South Africa, and of course it was being one of my previous employers. I'm very pleased to see so many of you here. University of Cape Town, Association for Dietetics of South Africa, the Nutrition Society of South Africa, and then I need to say all my colleagues here from Stellenbosch University. Wonderful to see you here this afternoon. So I'm delighted that Stellenbosch University can be the host of this wonderful and, do I need to say, much needed initiative, given the context of South Africa. By only considering the statistics of early nutrition, we can see why this initiative is so needed. Statistics in South Africa has clearly given an indication that we are burdened by what is referred to the triple burden of malnutrition in South Africa. Childhood stunting, the maternal and infant overweight and obesity, and it's due to the lack of proper diets and access to nutritious food, and then also coupled with the micronutrition deficiency that we see in especially the children of this country. This can impair the development. I don't need to share much of the impact of how critical the first 1,000 days is. And we've seen the work that Professor Mark Cotton has done, working with WHO, and the immense impact it has the moment that we can target the young infant. While we know that the recommended guidelines of infants should be exclusive breastfed for the first 6 months, what we see in South Africa that it's only 24% of mothers that exclusively breastfed their children up to the first 4 to 5 months in South Africa, which is a huge concern. In addition, the complementary feeding often lacks the variety and nutritional value. And we often see in practice the different customs that are taking place and practices, like adding some of the porridges, adding water, trying to put that into bottles, which is totally not what we want to accomplish in terms of dietary diversity. Today, here we launched the ImpENSA training program, which will equip healthcare professionals specifically with evidence-based knowledge. And that's another area that it's so much needed. Well, not only in our country for certain healthcare professional groups, but across the continent. And I really hope to see in future that what this group accomplish here will benefit the continent in later stages. But indeed, to make sure that the skills to support the pregnant women, their caregivers, to ensure that they will receive the optimum micronutrition intake in the first 1,000 days of their lives. So as a capacity building project, ImpENSA is indeed positioned to strengthen the relationships between higher education and the wider economic and social environment. But I need to say this project is much more than only looking at infants in the first 1,000 days of their lives. At the core, it is indeed about helping young mothers and caregivers and caring for their babies. And that's indeed one of the most basic human needs. And it provides a better future for children, for families, and then ultimately for the society. The other part that really stands out for me in this program is the multidisciplinary approach, not only between the different clinical areas, but also between different professions. And I've taken note that it's focused on nurses, midwives, pharmacists, nutritionists, the dietitians, and ultimately working with all the partners that is taking place, that has partnered in this program. So this is indeed an incredible, important initiative for South Africa. If we can make a difference in the first 1,000 days, I think we can break a cycle. I often say that nurses and midwives are in the position that from all the healthcare professions, they are really from birth, from the cradle to the deathbed. And ultimately, what I've seen in our country is the need for nurses and midwives to be trained to really make an impact in that first 1,000 days, because they are ultimately the first ones that are usually in contact with the mother and the baby. And I'm very pleased to see that this training program will indeed focus on empowering and in capacity building, and also with community workers. There's much in this approach that therefore resonates with how Stellenbosch University sees ourselves in terms of our vision, our strategic focus, making an impact. And that I can assure you from our side, we will be cheering on and making sure whatever it takes to support the team to make it a success. And do I need to add that we are indeed indebted to Erasmus Plus from the European Union for funding this program, and we hope that they will continue to fund it into the next cycle so that this can escalate and that the reach will be further. And ultimately that we will make a difference in what I believe is the most vulnerable part of the population, and that is our children from birth up to the first 5 years. So thank you once again for inviting me to welcome you on behalf of Stellenbosch University, welcome you on behalf of the rectorate and the management here of the faculty. And I hope that you will find this an absolute enriching experience. Thank you, Professor Blow.
Thank you so much to Professor Klopper, and for those of you, if you haven't really, picked it up, but she's a qualified nurse. So well done. We might also have another catch-up meeting to how to get our colleagues involved in this program. So it is now my great pleasure to introduce to you our guest speaker for this afternoon, Professor Shane Norris. He's a research professor with the Department of Pediatrics at the University of Witwatersrand in Johannesburg, South Africa. Shane is also the director of the South African Medical Research Council Development Pathways for Health Research Unit and the director for the South African Department of Science and Technology and the National Research Center for Excellence in Human Development. Shane research focuses on life course epidemiology with a specific interest in the development of intergenerational risk for obesity and diabetes. His expertise includes nutrition and body composition across the life course, as well as longitudinal cohort study methodologies. Shane is working with various scientists from Africa to better understand and to develop interventions to improve maternal and child health outcomes. So no one better to address us this afternoon in our keynote presentation. Thank you, Shane.
Thank you very much, Renee, and thank you very much to the organizers for inviting me to speak today. It's fantastic to see ImpENSA launch. It's been incubating for several years. I think it's absolutely going to make a real difference. And also it's fantastic to actually do this in person, even though we do have virtual colleagues join. And so it's so nice to see some colleagues from Southampton, from Germany, and local colleagues that we haven't seen each other for many years. So it is indeed quite a pleasure. So the role, the task that I was given is to really give you a broad overview of the triple burden and starting to narrow down into then the discussions that follow my presentation. So I'm going to go quite quick, 20 minutes, so it's a 20-minute around the world, if you want to call it, but a quick introduction and overview of the triple burden, hitting some key points and just some of the new areas that I think is important to note, but also where I think ImpENSA fits in terms of the South African context. So firstly, I want to start off with the burden of disease. This is updated now with up to the 2019 data. And really the key thing to highlight is, over the period starting from 1990 all the way to 2019, this is disease burden across multiple categories. The key thing to note is firstly, everything's going down. That's a good thing. So clearly the public health initiatives and research and medicine, we're driving the burden of disease down. This is particularly related to communicable and maternal, neonatal, and nutritional diseases. So we are globally making progress. However, on another point of view, in the same period, also updated to 2019, as we've seen the decrease in communicable, maternal, and nutrition-related diseases, we've seen a staggering increase in non-communicable disease. This is not saying that non-communicable and nutrition are not related, and I'll come to that, but it is an important picture to note that as we're making progress on one side, we're not making progress on the other, and in fact, it's inching up quite remarkably. So much so that already, almost a decade ago, for the first time on the United Nations platform, the declaration was announced to target and tackle the non-communicable diseases. So 10 years has already gone past, or 12 years almost a bit. But it's really to kind of now highlight that NCDs and the importance it plays in order for us to understand its contribution to the disease burden globally. What's really important in terms of the NCD rise, but also the burden that we see, is that the number of deaths by risk factors, this is globally for 2017, what's really critical is that many of the risk factors you see highlighted by the red arrows are nutrition-related risk factors. So even though overall maternal and child mortality and nutrition-related diseases are decreasing, we are still seeing that nutrition-related risk factors are contributing substantially to the major burdens of disease that's resulting in global death. So that's the global picture. Let's switch now to the components of the triple burden of malnutrition, starting with obesity. So obesity, this is data between 1975 to 2016. This is global data. Two things to really kind of focus on here is, so this is looking at obesity in men and women. So if obesity is equally spread across the different countries, it fits the red line. You can't see it too well, but the majority of high-income countries follow that profile. With low middle income countries, and in particular South Africa, a critical thing to note is we're way skewed to the right. So the proportion of obesity in women compared to men in South Africa is substantially different. And that's an important point to understand in terms of where obesity profiling is happening, but also in terms of intergenerational risk. Overall, in terms of adult female obesity, we've seen this increase substantially across the continent. Not surprising that this is driven by the nutrition transition, particularly economic development. And in this graph over here, as you can see, gross domestic product increases or improves in a country, so does it start shifting that nutritional status in that population with a greater prevalence of obesity. Obesity in school-aged children is also increasing substantially across the globe. It's recognized as a serious global health, public health challenge. Obesity has risen from 11 million to 124 million. So again, you're seen as globally with various low middle income countries increasing in the economic transition, the nutrition transition follows, and you're starting to see prevalence of obesity in children increasing. The important aspect is that this is not just linear, it's circular, and there's an intergenerational component. So as men and women within the population accrue risk factors, in particular obesity, those risk factors are then passed on intergenerationally. So adults with obesity are likely to have children with obesity, and in a really impressive meta-analysis with thousands of participants, showed that maternal obesity prior to conception had almost a 4-fold risk of obesity in the child postnatally. If we look at some of the local data, this is from urban Soweto near Johannesburg, just to kind of highlight that things change really relatively rapidly. So in this cohort, you can see the profile of morbid obesity in red all the way down to normal BMIs. And that profile was in 2003, just 10 years later. You could see the substantial shift of individuals moving not just out of normal BMI into overweight obesity, but into morbid obesity. That was in 2013. We've just looked at some recent data now from 2021, and the profile even looks worse than that. So in 20 decades, you've got almost 75% of this adult population we've been following up longitudinally obese or morbid obese. So it shows that things are just continuing. There's no stalling in this transition as these women age. Even within their children, this is looking at the birth to 20 index participant. This shows the longitudinal data from the time they were age 2 all the way through to age 21. You can see the divergence, particularly again between males and females as females enter adolescence. So by the time they're young adults, you've got close to 45% of females already overweight or obese, with males in the region of about 12%. We followed up this cohort when they were age 28, and looking at that data just recently, we see that again, the divergence between, or the sex difference still remains, but interestingly, between 20 and 30, we've seen a greater rise in overweight and obesity in the boys compared to the young woman at 28, with the young women still now moving closer to 55% of them being overweight or obese. This is all happening at young adulthood in the time that they're having children, so that intergenerational risk cycle is kicking in. Shifting away from obesity to the other end of the spectrum, to stunting. In this graph, it's not that clear, but really what we're looking at here is, again, as economic development happens in the country, what's happening to stunting. As expected, stunting goes down. And so this is the regional plots with South Africa positioned. So even though South Africa's GDP is increased and we move into an upper middle income country, we still have a persistence of 20% in stunting. So despite all the potential improvements we've seen with economic development, it's not breaking that persistent malnutrition, stunting-related risk factors. But at the same time, it's adding to the risk factors around overweight and obesity. If we look at the third burden, which is micronutrient deficiency, with anemia being the most common, again, this is looking at the plot of the prevalence of anemia versus change in economic development. And with South Africa's economic development, even though it has removed anemia, this is still the stunting slide, but it more or less mimics that what you see in stunting. That anemia, as with stunting, we're still seeing high levels of anemia in the region about 25 to 26%. So shifting gears a little bit, now moving to just from a life course perspective, starting with the preconception phase. These are data from young women aged 18 to 25, close to 1,750 of them, from Soweto, Johannesburg. Here you can see firstly their nutritional status, with close to about 25% of these young women overweight or obese, with the remaining normal weight and underweight. At this particular time point, we had roughly in the region of about 12% that were vitamin A deficient. Close to half of these women were in households that had food insecurity, and surprisingly more so than what we anticipated, we had about 27% of these women anemic. So you see that even in a household or an individual, you're having these clustering of potential risk factors, micronutrient deficiency, but the emergence of overweight and obesity. Within the context of food insecurity, this data was collected in 2019. We now know from data that's been released recently that food insecurity has been exacerbated in South Africa, partly driven by COVID. So you can imagine how scenarios are rapidly changing given these contextual pressures that are on households. In pregnancy, from another cohort, these women on average were about 28 years of age, presenting for the first time at an antenatal clinic in Soweto. This was close to just over 1,000 women. Of these 1,000 women, 67% were presenting at their first booking either overweight or obese. 31% were anemic, 10% developed gestational diabetes, 6% preeclampsia, 30% HIV, and a high risk of some form of maternal stress and depression. The remarkable and important aspect of this profile is that there were significant comorbidity sharing amongst the participants. Often women had 2 to 3 of these aspects, not just singles. So women may be overweight, gestational diabetic, and high level of stress and depression. So comorbidity clustering within these risk factors are also becoming much more prevalent, and our thinking of moving away from single state to much more viewing things holistically is absolutely critical. Just very briefly, we know from a lot of the epidemiology, both globally and within South Africa, that maternal nutritional status, particularly obesity, influences other components of both fetal and infant development, particularly the brain. Maternal obesity in early pregnancy is related to neurodevelopment delay. Pre-pregnancy obesity is related to reduced cognitive function in the offspring by between age 3 and 7. And infant early life weight gain is, particularly if it's rapid gain, is inversely associated with perceptual reasoning and working memory. So the scenarios are becoming far more complex in the sense of the effect of these nutritional burdens in terms of how it plays out for health, physical development, which is not just in terms of metabolic, but also the brain. So how do we start tackling these burdens? So firstly, it's through recognition, through agencies, and moving forward with public health interventions. So just as we had a really pivotal in 2011, the UN declaration around NCDs, we had a pivotal report coming out of WHO in 2016, which really positioned childhood obesity as a critical public health target to tackle, and they produced some key components that gave member states opportunity to think about various ways of intervening and tackling childhood obesity. And the report goes into the detail and the evidence around these 6 areas. The key thing to add is that the first 1,000 days, including the preconception period, was indicated as a critical developmental area to tackle in order to prevent childhood obesity. Moving to South Africa, so as South Africa was also starting to grapple with policy around tackling obesity, the Department of Health, with other departments, the Nutrition Directorates, etc., examined various case scenarios. And in this graph, really, it's just to kind of look at the time period through different public health initiatives, ranging from kind of health individual intervention through physician counseling, fiscal measures, food labeling, all the way down to school-based interventions. The key thing to take from this is that they all have different types of trajectories. Sometimes you can get a very quick impact, particularly if it's health provider focused, where some of the other policies like food advertising or food labeling can also have an impact, but takes time to kick in. So the importance is the balance when we're trying to tackle public health initiatives is how to see things in action from the time initiation to the effect that you're likely to see. But roughly, these are not quick. You can see that even 10 years into any of these interventions, you're going to have just a small impact. What this means is we can't rely on single strategies. We've got to be thinking multiple strategies on different levels with different sectors. Just to give you a quick snapshot in the same exercise that government went through, just to kind of give you a sense of the cost of these. Now, this is back in 2010, so you can imagine the costs of these interventions are very much different now in 2022. But it shows you that sometimes fiscal measures can be very inexpensive, potentially yield really good effect, but takes time. And indeed, this was the argument that really led to the introduction of the sugar-sweetened beverage tax in South Africa. But with this, we can get some sense of how to model effect, and they modeled the effect on BMI and the reduction of obesity over time. But cost of all these interventions need to also be balanced with both its effect and time to effect. Moving on to stunting and early child development, just to say that the WHO has 292 guidelines for improving maternal and child health. Of all the guidelines, 20% are nutrition specific and 15% would be nutrition sensitive. So a fair amount of these guidelines are nutrition oriented. What's really good news is that before I get to the really good news, 75% of these guidelines predominantly center around health system recommendations. The good news is that 62% of these 292 guidelines, South Africa already has adopted and implemented. So we are making really good traction on the adoption of WHO guidelines in this maternal and child space, and clearly it is taking effect. We are seeing stunting levels come down, even though it is persisting. We can't seem to just break that 20% barrier. However, despite all of this, it's still not enough. And that's, I think, the take-home message. Lots of recommendations, we're doing a lot, but there are stubborn barriers to us seeing the outcome we are interested in. How do we tackle micronutrient deficiency? I think there's many ways, and this is not an exhaustive list of intervention opportunities, but for me, an exciting area that I think is going to gain traction is shifting to a multi-micronutrient supplement in pregnancy away from just the iron and folate supplement. Unfortunately, with the embargo, I couldn't present data, but there's going to be a fantastic paper from the Harvard group which has amassed a massive amount of data and looked at the long-term impact of a multi-micronutrient supplement in pregnancy versus iron and folate alone on various outcomes. And it really overwhelmingly, for the first time, I think, articulates clearly potential value of adding a multi-micronutrient supplement in pregnancy as opposed to iron and folate alone. So I think with the new evidence going to come out and traction with data, that is a potential avenue that South Africa could move towards, is by introducing a multi-micronutrient supplement beginning antenatal. In addition, there's some really good work coming from folks here in the Cape and at WITS that's looking at the child support grant. We've seen good evidence to the impact of the child support grant on some indicators in the first 1,000 days, but we are also very aware that often women receive the child support grant much too late in infancy, and that delay in getting the child support grant for various reasons then impacts on the outcomes we hope to impact. So possibly shifting that into pregnancy, where women obtain the child support grant during pregnancy, or at least a big part of that process is achieved during pregnancy, so the money is available for the household by the time the baby is born, may be a very good way to go. And there's some excellent new economic modeling which is working with government along these lines. So I think in these two spaces, from a social protection point of view and from a multi-micronutrient point of view, I think there should be some interesting new traction in the short period of time here in South Africa in terms of policy. But clearly, with all the kind of potential efforts, we're far from hitting the targets we want. So life course nutrition, WHO has for many years now punted this life course approach, with evidence-based initiatives kicking in different phases of the life course, which is not just on the life course front, but also then intergenerationally. Just to give you some sense of where we at in South Africa, the sugar sweetened beverage tax certainly hits many parts of the life course, and that's been implemented, and some early evidence, as you've seen, that's been published from Karen Hoffman's group has shown the potential benefit already from that tax, with the potential of a multi-micronutrient supplement coming in during pregnancy. We already have good programs and foci around exclusive breastfeeding. We have the social grant program that could be improved. And the new Road to Health booklet was launched, which really brings in all this nurturing care framework and really takes it to that level. We've got food fortification, school meals. The areas where I think we're not focusing on, where there's both a lack of data, but also a lack of engagement collectively from practitioners and scientists and government, is around adolescence. Adolescence is really a kind of critical developmental stage. We've seen high levels of anemia, stunting even in adolescence, and overweight and obesity emerge, but very little is happening in this space. They are future parents, so there's also that intergenerational link. And as you've seen from the Lancet Adolescent Nutrition Series launched last year, there's a real need to kind of highlight adolescent nutrition as a critical policy area in conjunction with the first 1,000 days. These are not mutually inclusive or exclusive. They're a fact that they all build on from one another. And then the second area is really the pre-pregnancy component, with the growing evidence base of how pre-pregnancy maternal and paternal factors confer risk to the offspring. There's a real opportunity to kind of look at preconception and the first 1,000 days kind of in a linked way and using a more life course intergenerational lens. So in conclusion, the triple burden of malnutrition is substantial globally. It's clearly a substantial problem in South Africa. We've made some traction, but we're losing the battle on the micronutrient deficiencies, particularly anemia, and we're losing the battle on stunting. We're not breaking through critical levels, and at the same time, we're just seeing this burgeoning level of obesity in the country. Policies are in place, but the burden is persistent, and so we've got to find new ways to break through the barriers and achieve the goals we want to make on these indicators. Without a doubt, it's multifactorial, life course prevention. These are big tasks, big goals, but it is the way that we need to be thinking more. Adolescence, preconception, in addition to the 1,000 days, I think fit and provide potentially unique opportunities to bolster and improve efforts in the first 1,000 days space. What's really exciting is that the ImpENSA project really aims to talk to much of the triple burden of malnutrition through education, through empowerment, starting with health professionals. It's absolutely key. Everyone's a nutritionist, but we need people, we need health professionals that are in the know with the latest evidence, which can then pass on that effectively to their patients and the communities that they work in. So it's very exciting to be here at the point of the launch of this program, and just a big congratulations to all the partners involved, and thank you very much.
Thank you so much to Shane, and apologies for the lighting. We are going to have a quick video snippet from Professor Lucilla Poston. She is the head of the School of Life Force and Population Sciences at King's College in London. She's also currently the president of the International Society for the Developmental Origins of Health and Disease. And we thank her for the video that she sent us.
Hello, everybody. I'm Lucilla Poston. I'm the current president of the International Society for the Developmental Origins of Health and Disease, otherwise known as DOHAD. And thank you very much for giving me the opportunity to give a short talk today at the ImpENSA launch, which is focusing on the importance of nutrition from the earliest days of life through to early childhood, and that's what our society is all about. There's overwhelming evidence that suboptimal nutrition during these periods of vulnerability in early life, and indeed even amongst the nutrition of the child's parents before conception, is critical to the health of that child and of the child as an adult. We know that children deprived of essential nutrients during fetal development, who are then born small and whose growth trajectory is compromised postnatally, are never likely to achieve their full growth potential, nor indeed their potential in education or in employment. Conversely, children who are exposed to maternal obesity and the mother's obesogenic diet, and then an obesogenic diet themselves in the first 2 years of life, once born too large and then given a poor diet, are themselves likely to become obese adults who develop cardiometabolic disorders when they grow up. And to give an example, we've done a study in obese women and their children, most recently at the age of the children at the age of 3. And to give an example, we've found that obesity in the children at the age of 3 is independently associated with the mother's weight gain in pregnancy, her gestational weight gain, her absence of breastfeeding, and the obesogenic diet fed to the child. Those all are independent contributors to obesity in children at the age of 3. So demonstrating that both maternal diet in utero and then the diet of the child postnatally are critically important in the development of obesity. So when health professionals or indeed parents seek information on nutrition in pregnancy, what do? They are often very bewildered. There is so much incorrect evidence available out there on the internet and educational materials. Indeed, there's much outdated information available for health professionals in their training materials. And to give an example, most midwives in the United Kingdom are still taught to provide information on which foods women should avoid during pregnancy, such as tuna and liver, but not those foods which will provide the necessary micronutrients, the need for folate, iron, vitamin D, calcium, vitamin C, and so on, and free fatty acids. So those are the important micronutrients we need to supply the right foods for, but the information that women seek is still pretty poor. So my group in London actually did a survey. We were so worried about the information that people were provided during pregnancy of apps available on smartphones, which provide nutritional advice for pregnant women. And there were lots of them. And we looked in this study at those which were designed for English-speaking people, 29 different apps, and those which were very frequently used. Only 15 of those 29 apps contain reasonable, accurate nutritional information for women in the first trimester of pregnancy. And information on micronutrients was almost uniformly inaccurate in one way or another, really poor. And some of it was actually quite potentially dangerous, one in which was suggesting far too much iron intake during pregnancy. And then the apps also attempted to provide behavioral change techniques for pregnant women. And in the ones we looked at, there were 10 different methods recommended to help pregnant women change their dietary behaviors. There was also very little attention to the difference in diets between ethnic groups. Of course, it's absolutely essential that dietary advice is given in the context of culturally relevant dietary components, and that is so often absent in the advice given to, particularly in the United Kingdom, our very multi-ethnic population. So there's therefore an important need to provide evidence-based advice for health professionals. I think we're all agreed on that, so that they themselves can help mothers and their fathers and the fathers to change their dietary behaviours. Both the parents need to be involved, and both the parents need to be involved in improving the diets of their infants. And that advice is sadly lacking at the moment. So investment in nutritional advice in the early days of life is cost effective. We know that in the United Kingdom, there was a health economy investigation into an intervention which was given to children with vitamins and other micronutrients. And it was found to be very cost effective because those children who were given the supplements went into hospital less often, so that was a cost saving, and also had a generally healthier life. In South Africa, with the population transitioning from traditional to Western dietary habits, there has never been a more important time to introduce the ImpENSA program. And it looks an extremely useful program. It looks to be very user-friendly from what I've seen. And I wish you great success with your very important adventure. Good luck, everybody. And I am sure you will do a fantastic job. Thank you.
Thank you to Professor Poston in her absence. So next on the program, we have Mr. Gilbert Chisauti. He is from the UNICEF office, the nutritional manager at UNICEF. Gilbert has previously worked in various capacities in the South African government health sector. Most recently, he was at the Nutrition Directorate. Over the years, he has served in many capacities and has gained a good understanding of the South African health system, nutrition programming, policies, and strategy development. He has experience in infant and young child nutrition, clinical nutrition, HIV, and nutrition programming. Gilbert holds a master's degree in health economics from the University of Aberdeen and a master's degree in nutrition from Stellenbosch University. Thank you so much, Gilbert.
Thank you very much, Prof. Blau, for the introduction, and good afternoon, colleagues. I think it's good to see some familiar faces. We haven't engaged with each other in the past 2 or 3 years or so, but I think it's good to be here, and thank you very much for the invitation. As UNICEF South Africa, indeed, this is a very exciting project, and we are here indeed to support this initiative, given really the context that we operate in South Africa. Yeah, this is just going. It's going to be a very short presentation, and this is what I'm going to cover in my presentation. Really, our context, so that you understand, where we come from as UNICEF, especially, from the South African perspective, and how we view maybe, this project in terms of its sustainability, and also moving forward in addressing really the nutritional problems that, we are faced with in South Africa. And this is the context that we operate, within. I mean, my colleagues have already alluded to this, and we know the problem of childhood stunting, the anemia, especially in your childbearing women, the issue of childhood overweight, exclusive breastfeeding. But I think what is of key interest is when we compare ourselves with these global targets. The typical example, the World Health Assembly 2025, global targets. If we continue in the same trajectory, we are unlikely to meet some of these global targets. One, in childhood stunting, you can see as we stand right now, we have got 1.5 million children who are stunted. But if you continue, if nothing really happens, if we continue in this trajectory, we are likely to have more than 1.6 million children who are stunted in 2025. Looking at the anemia, we're also off track, although there is a little bit of some progress, but the situation doesn't really look good. With childhood, overweight and obesity, although we seem to be on progress, we really don't know what the situation is right now. This is really based on the survey that was conducted in 2016, and we know that a lot of things have really happened. Hopefully, I mean, the upcoming data survey will shed some light in terms of the current situation around childhood overweight and obesity. With exclusive breastfeeding, we know that as South Africa, especially when we compare ourselves with our neighboring countries, we were fairly low, somewhere sitting at 32%, and we don't know if the situation is improving or regressing. And this is a very critical area, and more especially when we're talking about this context of the first 1,000 days of life. And we know how the triple burden of malnutrition harms children, adolescents, and women. So I'm not going to bore you with these slides. I think Prof. Norris has really, alluded to some of these issues. Issue of, undernutrition, stunting, and wasting, the hidden hunger, overweight, and obesity, their impact on the development of children and adolescents. And this is a very critical area for us, especially the adolescence piece. We know that it's an area that is always ignored. And most of the time when we think of interventions, we always clump adolescents with adults together. We often ignore our young people, and we know that they're the future. And this is a very interesting area. It's an area of interest for us as UNICEF in South Africa, more especially also in the NCD space. But looking at really where this project focuses on, especially when you look at the 0 to 5 month and also the 6 month to 2 years, when you look at the issues that really influence how children are fed, and also really the risks that that underlines that critical component, it's very critical that we address some of these issues. When you look at your 0 to 5 years, what are the main risk issues that we need to deal with? Lack of exclusive breastfeeding, the marketing of breast milk substitute. This is really one of the major risks that really impact on how children are fed. And obviously that will have an impact on the development and really the nutritional outcome that we're looking at. When you look at your 6 months and 2 years, the lack of data diversity, which obviously will also have an impact on the growth and development of the children. And also, the low feeding frequency, which we know that is an issue. The whole issue of complementary feeding in South Africa is always a challenge, and it will always be a problem unless something is adequately done to address that particular issue. Eating of ultra processed food, which is also linked to the whole issue of really overweight and obesity. And we know that malnutrition is happening in a changing world. We need to take some of these things into consideration. Urbanization, it's a new challenge that we need to look at, and we need to ensure that our interventions really seeks to address some of these challenges. The globalization, climate change, and emergencies, which we know that as we speak right now, we are in this health emergency, which is COVID-19. And all of this can lead really to the worsening nutritional prospect of millions of poor and excluded children. So as UNICEF, how do we look into these things? Looking at our UNICEF Nutrition Strategy 2030, our goal really is to protect and promote diets, services, and practices that support optimal nutrition, growth, and development for all children, adolescents, and women. So when you look at these three components, good diets, good services, and good practices. And we also believe that through some of these interventions, like your ImpENSA project, we want good services to be provided to caregivers and children, and which will then lead to good practices, the change in behavior. So you can already see really how this initiative really fits in very well with our goal, which really talks to how we respond to the nutritional needs of the South African children. But really, we need to go beyond that. We know that most of us are very comfortable working with the healthcare system. But there are these other systems, which I think Prof. Norris also alluded to, which are very critical to improving the nutritional status of children. The education system, it's a very, very critical platform that we need to look at, more especially when we want to address issues that talks to ECD and also your school-going children. The social protection system, it's a very, very critical component. We cannot just really talk only about the health system without really addressing some of these systems. But really at the center is the food system. We know that there are major challenges with with our food system, and without addressing those fundamental issues that we are faced with in South Africa, we are not going to move further. The quick interventions that we want to come up with are not really going to address really the long-term issues that we're dealing with in terms of really addressing improving the nutritional status of the South African children. So really, as UNICEF, this is really, we are looking at these things from a systems approach. How do we talk to different systems? How can all these different systems improve the nutritional status of children in South Africa? All of them have got a critical role to play. And I think more especially the social protection became even more critical now during the COVID-19 pandemic. We've seen the importance of this system and what it can do. And when we look at programming, this is our programming approach as UNICEF. We look at the situation. What is the situation? Our context in South Africa. And then look at the various policies and strategies that exist. And obviously, our work really resides mainly around these critical areas that I've highlighted in red. Advocacy, capacity development, be it capacity development of healthcare providers or individuals and caregivers. Supply provision, obviously there has to be supply provision. If you're talking of micronutrients, supplementation, the supply system need to function. Community engagement, which is very, very critical, more especially when you going to take some of our interventions to the community level, because we know that this is where we can make a lot of changes and make meaningful impact in terms of really addressing the problem of malnutrition that we're faced with. And also partnership is very critical. We need to partner with various stakeholders, those whom we share, the same goals with. We need to partner with them so that we can improve, because just as maybe as academia or as UN agencies and as government, we can't do it alone. We need to partner so that we can indeed, improve the nutrition situation of our South African children. So how do we see, really the sustainability of this ImpENSA initiative? Having worked, I think, in both, both sides, in government and now working with the UN agencies, we really need to appreciate the South African context, particularly, I think, the health system, because this really becomes our entry point to improving the nutritional status of South Africans. And obviously, there are quite a number of ongoing initiatives that, this project can piggyback on. And there are quite a number of initiatives that this project can actually, try to escalate to different levels. And I think these are the opportunities that we need to look at and explore and see how best can we use some of those existing platforms to launch this, and also ensure that we really talk to the South African context. And we also need to take into consideration on how best can we integrate this initiative, which is a capacity building initiative, with some of the existing initiatives. There are quite a number of existing, typical example, there are platforms that exist. I'm sure most of you are familiar with the Knowledge Hub, which I think is one of the platforms that I think the government, especially in health, are using to communicate mainly with healthcare providers, health professionals. So we need to see how can we also use some of these platforms, making sure that the content really can address the needs of people who have access to those existing platforms. There are quite a number of platforms that currently exist. And I think what is of critical importance is that prevention is key, and really building the advocacy piece for systems approach in the first 1,000 days will be very critical, I think, for this project. How can we activate, for example, the social protection system, so that it can address issues that talks to your first 1,000 days? How can we activate, the food systems, all those different systems, so that they can talk to the first 1,000 days? this is very critical, and this is how we look at addressing, the problem of malnutrition. And building on the community health worker platform is very, very critical, especially in the South African context. We know that it's a very contested platform at the moment. It's a little bit, it's in a disarray depending on where you come from. If you get to KZN, you get a very different perspective of what is happening around the community health worker a platform. You come to the Western Cape or into other provinces. It's a highly contested space and not really well organized. But I think what is of critical importance really will be what is happening around child nutrition related issues, maternal and child nutrition in this platform. So how can this project really start really to address some of the challenges, which some of them are really systemic issues, which you need to be aware of, and how can really this project play that catalytic role in terms of really starting to improve maternal and child nutrition at that level. This will become very, very critical for also really for the sustainability and also for starting to address some of these fundamental problems. Building partnership, of course, really going beyond really maybe just, yes, as at the beginning, yes, you need few people, few maybe institutions, but I think it would be good really to go also beyond the few institutions that are part of this consortium, but just to also include other stakeholders who may play a critical role. More especially, I think, really government colleagues. There is a need really for buy-in and also for their active involvement really in the rollout of this project. Thank you very much. I think I'll stop here.
Thank you so much, Gilbert. I would like to now introduce the big boss of the ImpENSA project, Professor Bertolt Kuletsky from the Ludwig Maximilian University in Munich, Germany. Thank you, Bert.
Thank you, Renee. Distinguished Deputy Vice Chancellor, Dean Feinstein, dear colleagues, ladies and gentlemen in this wonderful auditorium and those joining us online. Today is a really happy day, not only for myself, but all the partners of the ImpENSA consortium, because finally, after 3 years of intensive collaborative work, we are ready to launch a wonderful and exciting training program. I'm Bertolt Kuletsky, as you heard. I'm a pediatrician working at LMU, the University of Munich in Germany, and I have the great privilege to serve as a coordinator of this consortium. So my goal in this short presentation is to give you a little bit of an insight and overview of the ImpENSA training program, and this will be followed by further comments from the different consortium partners on different aspects of the program. So our goal is to address what you've heard already so well from Shane Norris and now from Gilbert, the challenge of the triple burden of malnutrition that South African communities, people in South Africa face and are challenged with. And our approach is to build continued professional development for healthcare professionals with development and implementation of innovative, evidence-based blended learning that focuses on micronutrient nutrition during the first 1,000 days. So the idea is if we empower those who counsel families, women that plan a pregnancy or will have a pregnancy, we will reach out and improve the health and lives of the next generation. And basically, the whole concept is that we try to apply the immense knowledge that research and science has developed over recent decades on the importance of the first 1,000 days, the environment and nutritional influences on health and development into practice. The program combines the capacity of 6 universities, 3 in South Africa, 3 in Europe. You see them here. The Northwest University in Potchefstroom, Stellenbosch University, which is our host today, University of Cape Town, and then in Europe, University of Munich, LMU, University of Southampton, UK, and the Medical University of Warsaw in Poland, and 2 professional organizations of the South African Dietitians and South African Nutrition Society, ATSA and NSSA, who work closely together with other partners. We have funding received from the European Union, which makes all this possible, of about 1 million euro, equivalent to about 16 million rand, for a period of 4 years. So what is our focus here? Again, we are trying to reduce the triple burden of malnutrition with less child malnutrition, micronutrient deficiency, and obesity being our main targets. We want to improve neurodevelopment and learning ability of children, increase school readiness and educational achievements, reduce stunting and malnutrition, and reduce obesity prevalence. So all of this is very much in line with the SDG 3 of the United Nations. How did we approach this? We built 6 parts of our work. We started with an in-depth analysis of the South African landscape, of the education programs that are available, and the gaps and needs that remain. And based on that, we developed then the content of our training program, and we invested in a state-of-the-art e-learning platform, basically believing that digital learning is really the way to go to reach a lot of people with a low barrier, which is so easy nowadays. You can do it from your smartphone, from your tablet, from your computer, at any location, at any time, without much investment in time and traveling and costs. We then implemented what we had developed and piloted it. We have very detailed evaluation, and you will hear later on that the evaluation results are absolutely smashing. We had extremely positive responses, and we are launching this today, and then we'll continue to disseminate it, try to exploit it in terms of bringing it out to as many users as possible, and are working on sustainable rollout, as well as taking the next steps. You heard from Gilbert already how important the healthcare workers are, so that's our next goal for the future. So we started with this landscape analysis, and these are the key recommendations that came out of the landscape analysis. First, the conclusion: we need to invest in blended learning, e-learning to disseminate knowledge, the information on micronutrients in the first 1,000 days, theory and applied knowledge, and facilitated learning that would then allow people to use that knowledge in optimal conversations with families. We clearly felt there is the need to have an evidence-based, up-to-date content, focusing on practical relevances, on messages that can be applied, and behavior-changing communication skills. It was felt that providing CPD points and a certificate is important to facilitate the use and acceptance of the program, and with particularly the 2 elements, the e-learning and the facilitated learning, it was felt to be very important to engage the learners, not to make them passive, but to make them very active participants, and we have invested a lot in that. Use generously visual media and simulate practice with case studies and case scenarios. So again, this is our journey over the last 3 years: the needs analysis, the landscape analysis, the development of the module descriptors and the contents, development of the educational design and the media, and then the implementation on a platform that is the most commonly used platform in medical education, the Moodle software. So we had to take a lot of decisions on target users, topics, learning objectives, the time that could be allocated. Of course, if somebody is in the topic, you want to try to share every little detail of the information, but you have to make a compromise and then make it practical. And the mode of delivery, we had to consider pre-existing knowledge and the level of education of our target groups, and very important, the context and relevance for the South African users. National and global guidelines and policies had to be taken into account, existing tools and educational material, and of course the latest scientific information. That, of course, is a big benefit of the e-learning approach, that you can very quickly adapt the content to current knowledge. Now, this looks all very straightforward, but then in between, suddenly a virus came. So we had 2 wonderful meetings, one in Potchefstroom at the Northwest University, and then one here in Cape Town, and then suddenly we could not meet anymore with the partners from Europe and South Africa. And I can tell you, many of us were very concerned what is going to happen to our project, and I must say, I'm so impressed how well it went, only with online meetings and online collaboration. And this is really due to a fantastic group of partners. We built some good interaction in the first 2 meetings. Some of us knew each other before, and I'm so impressed, I must say it again, how well it worked in spite of these challenges. And we are very happy that we can meet again this week at Stellenbosch University. So this is how the training program looks like. We have this e-learning module 1 with a learning time of 3 hours that provides knowledge on optimizing micronutrient nutrition during the first 1,000 days of life. We have the module 2, learning time 2 to 3 hours, that provides the background for communication to support behavior. And then we have a facilitated module 3, which can be applied as face-to-face training together in a room, or as a virtual training, which is called Healthy Conversation Skills to Support Behavior Change. So in other words, we are training people how to best communicate with the target groups. And I can tell you, it's really a fantastic program altogether. Again, it has a lot of modern tools, media, video scenarios, interactive elements. It's really fun to do it. So I invite you all to go to this website, earlynutrition.org/ImpENSA, and get a glimpse of it and try it out. And if you like it, share it with your friends and colleagues. E-learning components, again, evidence-based content, focus on practical application and recommendations related to national and international guidelines, and using amply interactive media to make it fun and to involve the learner very actively in the process. We have a number of in-lesson activities where the users have to answer questions and do like a quiz. We have scenario-based videos that show the practical reality of counseling, and we have animated videos for contextualized examples. I told you we have the facilitated training of the healthy conversation skills, and here we had to train trainers, and this is what basically the process is. They go through the 3 modules themselves, and then there's a 4th module to basically train the trainers with all the skills to then apply this training to the target groups. We hope we have really built a lot of additional capacity in fostering the position of South African universities as qualification providers for healthcare professionals, expand the expertise of the staff in South Africa in e-learning and blended learning based on the latest science in early nutrition and education research, as well as instructional design. Establish infrastructure here for effective and efficient generation and delivery of blended training and strengthening of counseling skills, and implement now an effective CPD evidence-based digital training course, again with knowledge and counseling skills being provided on nutrition and lifestyle in early life that match the specific needs of the target group here in the country and is not covered by currently available other programs. This is great, but we have more to do. We have, as I said, evaluated the course. This is still ongoing in the next phase. We have extremely positive feedback, which makes us very happy and motivates us to go forward. We have the accreditation of the training programs with 15 CPD points. We are launching this today for wide use, both by healthcare professionals who are in service and by trainees who are preparing to become healthcare professionals. We aim at close collaboration with partners such as UNICEF, the Department of Health, healthcare professional organizations to support wide implementation. We have the commitment of LMU Munich to continue technical and hosting support, and we are in the process of building a non-profit organization hosted at NWU that will be able to sustain the training course delivery and also the enhancement of the program over time. And we are hoping now to apply for a new grant to continue this to the next level and also reach other target groups. We heard about the importance of the community health workers that we would like to target more specifically. So if you want to get more information, go to our website, early-nutrition.org ImpENSA, which is also the entry point to the program. And you can also, if you look at the bottom left, sign up to the ImpENSA newsletter there with one click, and you get all the new information automatically then. You can go to our YouTube channel, YouTube ImpENSA. If you Google that, you find a lot of fun movies that give you much more insights into this. You can go to the Twitter account, ENA at Early Nutrition, or just write an email if you have questions and want to know more. With this, I thank you for your attention. Thank the European Union for allowing us to do this with the money that they have granted. A truly amazing ImpENSA team that has done a fantastic job and actually was great fun to work with, and we are still continuing working together and hopefully will do for a long time. All partners and collaborators of the program. And now it is my great joy to start the rocket and formally launch the ImpENSA training program. May it fly long and strong and be very successful. Thank you for your attention.
Thank you so much, Bertolt. Can I please ask the partner representatives to come to the front? We're going to put them a bit on the spot with a couple of questions. To our colleagues and friends standing to my side, basically for them to share a little bit of their journey with you. And it's going to start with Shweta, so you can give her the first one. Thank you very much. So Shweta, she's representing the Ludwig Maximilians University in Munich. And Shweta, I'm going to ask you that we've heard about European Union, Erasmus+, capacity building. So can you maybe elaborate a little bit on the interaction between all of these components, please?
Thank you, René. So EU, that we say, European Union, as we all know, is the union of European countries, And European Union basically has several targeted policies and actions to collaborate with low and middle income countries. And Erasmus Plus program is one such action that targets the education and training part. Now, within EU Erasmus Plus, there are several initiatives, and capacity building in higher education is one of them that is mainly targeted to modernize, to internationalize, and to increase the outreach of education to everyone. Thank you very much.
Thanks, Shweta. I'm moving to Estelle Stradom from Northwest University. So, Estelle, you were involved in the development of the training programs. Can you maybe just give us a little bit of background of the process?
Thank you, Renee. Is this one on? Thank you. So yeah, like Professor Coletto said, it started with a landscape analysis where we conducted focus group discussions to identify the training needs of healthcare professionals in South Africa, as well as a scoping analysis to determine the existing training landscape. And then based on this needs analysis, the topics of the modules was confirmed, and we made a curriculum recommendation. And then leading experts in the field of nutrition as well as behavior change then developed the content. And for me, the most hard work, but also the most rewarding part of this project was the learning design, where we took this content, basically just text, and transformed it to something that can really successfully facilitate learning on an online platform. And we developed lots of different activities, in-lesson quizzes, lots of various types of media elements, interactive graphs, videos, both real life and animated. And while this might sound fairly simple, I can promise you it was months of hard work, going around, thinking about different ideas, how the learner might find something, debating about whether a line should be orange or red. And then finally, the professional media teams developed or created the media element, and we realized the line can neither be red or orange, it should actually be green. And then finally everything was put on the storyboards and then facilitated onto the online platforms. So I really hope you all are looking forward to doing the modules and seeing that it's really not just like any other training you've ever done before online. It's really quite something. Thank you.
Even if we say so ourselves.
Even if we have to say so ourselves.
Thank you, Estelle. I'm moving to Wendy Lawrence. She's representing the University of Southampton. So, Wendy, the third module is all about skills-based training. So, what can you tell us about that?
Thank you, Renee. Yes, so we can provide information and education for people, but when we actually want to convey that to our patients and our clients, we need skills to be able to have those communications and to have those conversations. So at the University of Southampton, we have spent the last sort of 15 years, myself and my team, developing, delivering and evaluating healthy conversation skills. This is a training program. It's always been face-to-face because it's about communication. And it's very much around how do we best have conversations to support people to make change. We assume if we tell people what they should do, that they will do it. And I think many of you that work in clinical practice will realize that that's not actually what happens. So we find it essential that we develop those skills. And so this training, healthy conversation skills, I've been fortunate enough to have collaborations all around the world. So we have people trained in these skills in different professions in Australia, New Zealand, China, India, Canada, South Africa, and in the UK. So many years of evaluating it, and we have quite a few publications to show that we can make a difference, and that's what we say about healthy conversation skills. So it's changing the world one conversation at a time. So I'm looking forward to seeing that develop and roll out across South Africa and seeing what impact it can have. So thank you, Renee.
Thank you, Wendy. Moving to Kerry Sexton, University of Cape Town. So Kerry, after we've developed the modules or the material, what can you tell us about the implementation of the training material?
Thanks, Renee. So after extensive development of the modules, and with Wendy's expertise in healthy conversation skills and in training, we were then ready to roll out the next phase of the project, which was a train-the-trainer module, and then also the piloting of the training program by these newly trained trainers. So thanks to COVID, as Prof. Koletsko mentioned, our original plans to hold the training in person had to be adapted. And after some creative thinking, we had to move both the training and then also the pilots into the virtual sphere. So in September last year, we recruited 4 colleagues from Stellenbosch University, Northwest, and also the Western Cape Department of Health to undergo this training, which would all be facilitated by Wendy. And this entailed initially 2 4-hour healthy conversation skills, which with the participants, and then after healthy conversation skills, we had extensive coaching and mentoring sessions by Wendy, all live via Zoom. What we also included were some coaching sessions by a tech expert on how to use Zoom effectively. So we wanted to mimic the live, in-person, face-to-face healthy conversation skills. So our new trainers did these tech sessions and learned how to use functions on Zoom like breakout rooms and the annotate function. After this extensive training, we were then ready to roll out the pilot. And this we did in November. So both for the training for the coordinator or the trainer training, and for the pilot, we recruited participants via ADSA, the NSSA, and then various other networks. The pilot we started in November last year, as I said, also virtually, and each trainer conducted 2 pilots that were conducted they facilitated in pairs. So the participants did the 2 online modules in a 2-week period. So that's module 1 and module 2. Once they'd successfully completed that, they were then assigned to one of the 4 pilot groups with the newly trained trainers. So all in all, at the end of the training and by the end of the pilot, we had 55 participants in total, predominantly dietitians with some nutritionists and some nurses who underwent the training program. So they successfully completed the ImpENSA training program and were awarded 15 CPD points.
Thank you, Kerry, and thank you so much to the 4 coordinators that have been trained. That's Estelle, Lisa, Runel, Nikki. Thank you so much, guys. We know that it was a lot of your time and effort, but we hope that you have enjoyed the journey and that you've learned a lot of new skills. So thank you for that. So we now move to the Medical University of Warsaw, Jan Lukasik. So Jan, every intervention needs some evidence of effectiveness. So what can you tell us about how you went about to evaluate the process?
So basically, we had the key questions we had to answer were what is the effectiveness of the ImpENSA program in enforcing healthcare professionals to better enable pregnant women and mothers to optimize healthy nutrition of their children through positive behavior changes. And to answer these questions, we decided to use mixed methods, which encompass both qualitative and quantitative data. And to gather this data, we have devised a number of tools, including questionnaires, assessments, and interviews. And these tools, in their current form, is what I must say, an effect of hundreds of hours of work, not only from our team, but also from all the other members. So where are we now? Currently, the data collection is in its final stage, which is the follow-up study. and we already have collected all the remaining data. And while the analysis is still ongoing, we already have an overview of the feedback from the participants. And this overview, as you already heard from Professor Kolecko, it's overwhelmingly positive. The participants were enthusiastic both about the structure of the course and about its content, including, maybe surprisingly, the online mode of delivery, which was forced by the COVID pandemic. Moreover, the overall opinions about the course are also very positive. There were opinions that it was one of the best courses that the participants have taken part in, and also suggestions that the course should be delivered to other groups like healthcare workers. So those few words that I can say here is just scratching the surface of the data which we have, but we can already with confidence say that the program is working as it is intended to. Thank you.
Thank you, Jan. And then last but not least, Christine Taljaard-Kruger. So Christine is representing, for the purpose of this talk, the Nutrition Society as well as ATSA. So Christine, quite a few interactions between the core ImpENSA group and the societies. Can you maybe elaborate on that part, please?
Yes, thank you, Renee, and good afternoon, everybody. So yes, I think both the society and the association were quite involved throughout the project, be it providing input into the module content, be it the evaluation, or be it article writing. But I think the core issues where they were really involved in is taking the project to the nutrition professionals, so taking it to the dietitians and to the nutritionists. And this was mainly done through the society and the association's mailing system and mailer list. So I think respectively, ATSA and NSSA sent out 9 and 7 emails with about a total of 900 clicks per email, or per total emails that went out. And I think that was really a key way in how the nutrition professionals were reached and also being informed about the planning project. Thank you, Renee.
Thank you so much to everybody. So you can please. So we are moving to the second from the last presentation. So I'm going to hand over to Professor Lisa Havermann-Nell from the Northwest University just to discuss a little bit about the way forward. Thanks, Lisa.
Thank you very much, Renelle, and good afternoon, everyone. So you've just heard from our respective consortium partners regarding the process and how we went about to develop a wonderful early life nutrition training program, the ImpENSA training program. We've just launched this program, and also you've heard from Christine that, you know, the number of clicks and the number of responses already, and, you know, when we advertised the pilot, we already had a huge interest from various dietitians and nutritionists, especially to complete the program. So obviously with the pilot, we could only accommodate a limited number of participants. So we've already, especially following the pilot, we're receiving interest in this program. So we've launched this program. So what now? So our first priority now is to formally roll out this program. Then our next priority and focus will be to improve or increase the reach and the impact of the program. And then ultimately, we need to ensure that what we are doing is sustainable. So just in terms of the immediate rollout, when can you guys, and where and how and what can you enroll to take part? We will be implementing the existing ImpENSA program with last tweaks and changes and feedback from the evaluation team, and we will just also ensure that the content is up to date, because remember we developed the content during the past 3 years and the environment is changing quite rapidly. We will then also re-accredited the official program for rollout, and then we envisage that this program will be rolled out officially between August and November this year. We will only implement a limited number of trainings because we are still within project lifetime, and we can only handle in a certain capacity at the moment. The program will be free of cost for 2022, and then we will be mainly targeting healthcare professionals working in early life nutrition, including the dietitians, nutritionists, but also the nurses, midwives, pharmacists, and medical doctors. And we will probably spend our initial focus on trying to get the dietitians who are currently really excited about this program, because remember, a lot of the AdWords were circulated through the ads on NSSA mailers, so we are currently receiving quite a bit of interest from them specifically, so we would like to offer especially the first few spaces to them, but of course first come first serve, but everyone who's interested is welcome to try and enroll. With regards to impact, we would obviously like to have a bigger impact with this program going forward, and for that, we need to slightly adapt the program to reach all healthcare professionals working in early life nutrition, including those working in private sector, but also public sector, but also those working in rural, remote, and low resource areas. So you've heard from the other presenters that we currently have a virtual healthy conversation skills model and module, which has got its advantages. But we've also picked up to really reach the hard-to-reach places, and especially the low-resource areas, and the groups like the nurses. The face-to-face model may work better. So we will be converting the virtual healthy conversation skills to include face-to-face delivery as well, so you can have both in order to reach a wider target group. And then further down the line, we've heard very nicely from Gilbert that ultimately we would like to reach the healthcare workers with our training program. Currently, the program is developed on NQ level 6. It's developed specifically for the healthcare professionals, and we will need to scale it down in order to effectively also reach the healthcare workers. So then finally, in terms of sustainability, it's great to have a program, it's great to have plans, but we need to make it sustainable. And for that, we will establish a social enterprise. We will need to engage relevant stakeholders, for instance, the Department of Health. Hopefully UNICEF sounds very positive about our program. And also we will have to probably include possible funders. Again, we will probably also need to explore more avenues for implementation. Bert also referred to a follow-up project funding proposal to try and secure more funds to enable us to go forward, and then also to ensure sustainability. The program will need to adapt and respond to the current changing public health nutrition-related needs. Again, if you would like to get more information on the ImpENSA program, Bert also referred to these routes to get more information. And I hope that you guys are as excited as we are to learn more from the program, and hopefully to take the training one day and get on board and get involved. So from my side, thank you very much.
Thank you, Lisa. And then I'm going to call on Shweta again to please handle the closing.
Thank you very much, Rani. Thank you very much, Rene. So as I spoke earlier about the EU Erasmus Plus and the capacity building objectives. At the closing, I'm very proud to say that there are a lot of objectives that we have already achieved, and some of those are that we have improved the level of skills in partner universities by creating an educational program, which is the ImpENSA training program that we just launched. We have strengthened the capacity of management, of innovation, as well as internationalization for our South African partners. We have built the capacity for partners to modernize their own higher education systems, and we have now laid the foundation for cooperation across different regions in South Africa. So it would not be an exaggeration to say that in terms of EU-SA collaboration, ImpENSA project has set a high benchmark. So we have a little video that Stellenbosch University has prepared, and enjoy the video.